Thank you all so much for joining us this afternoon and for giving up your time to help my GP colleagues learn a little bit more about gastrointestinal stromal tumours. A bit of a mouthful. Welcome to Satvinder Midan. You're an upper GI cancer surgeon, formerly at the Royal Marsden and St George's Hospitals and now based at the London Clinic. Charlotte Benson, welcome. You're a consultant oncologist.
That's right.
At the Marsden, specialising in sarcoma, and you work alongside Robin Jones, who's also a consultant oncologist. Sarcoma. There are two types, aren't there? There's bone sarcomas and soft tissue sarcomas. Is that right? So, Charlotte, where does GIST come in?
So GIST falls into the soft tissue sarcoma category, right. And it can arise anywhere in the gastrointestinal tract. And they represent about 30% of all gastrointestinal sarcomas. And what's important is that they can affect children, adolescents and adults.
Okay.
GIST, or gastrointestinal stromal tumour, is a type of soft tissue sarcoma. There are more than 50 different sorts, but this is actually one of the commonest. In fact, we think it's the commonest sort, approaching 30% of all cases. The most reliable figures we have for the incidence of the disease gives a number of 11 cases per million per year. So that would give us about 680 cases or something like that for the whole of the UK. So it's not a common disease, but nevertheless it's an important one.
The symptoms of GIST are often quite vague and might be persistent anemia or abdominal symptoms or indigestion.
And that overlaps with quite a few other things that we see in our day-to-day practice as well, which we'll come back to a bit later on. But Satvinder, why is it important to diagnose GIST tumours early?
I think the importance of diagnosing GIST early, as with a lot of other cancers, is that frequently surgery alone is going to be sufficient to achieve cure for the patient. So there's no requirement for further treatments, and that's an important thing.
Okay, so that would be better for the patient's outcomes and for their experience to have their cancer diagnosed earlier. So what sort of symptoms, Charlotte mentioned a few, but from your point of view, could you advise us about, I'm particularly concerned about dyspepsia.
Yeah.
So we have a lot of people that don't fulfil the 2-week wait criteria for direct access endoscopy. How would we manage somebody who comes into us with dyspepsia? Do we give them a course of antacids and...
Well, I think, I mean, you're right. These are common symptoms in any general practice. And I think it's the persistence of symptoms that probably is the important thing, and whether there are associated symptoms such as weight loss. So I agree, a lot of these patients with early disease are not going to have the emergency criteria for 2-week assessment. I think that's right. And there needs to almost be a different pathway to look at those patients. So the symptoms of stromal tumour may be mixed in with other tumours, gastric cancer, pancreatic cancer, a variety of other things in their early stages before you see the late symptoms. And I think it's the persistence of those symptoms, and especially in somebody perhaps who doesn't normally attend the GP surgery because he's very well and then comes suddenly with persisting symptoms. I think that's
a red flag for us.
I think so. That's the kind of patient that I'd be anxious about. So the majority of certainly stromal tumours are going to present with those kind of vague symptoms, and the patient then go into an investigation pathway and be found to have probably a stromal tumour in the stomach. But you're right, the symptoms may well overlap with a variety of other, both cancer and non-cancer diagnoses.
IBS, ovarian cancer.
Absolutely.
That's the big one that we know as GPs is incredibly hard to diagnose. So I know that you all work at a tertiary referral centre for GIST tumours. Are there other centres around the country? Is it somewhere that we should be sending our patients to?
Yes, there are other tertiary specialist centres around the country. I think it's really important that patients with these tumours, these rare tumours, are managed by specialist teams. It can be very difficult to make the diagnosis, and it's important.
Need a specialist pathologist.
Correct, absolutely.
Okay. And radiologist and
in time, multidisciplinary.
And to actually manage, so that's where you would come in as oncologist to decide with the post-surgery whether a patient needs treatment. We'll come on to that in a moment, but I think I would guess as a GP, with all the vague symptoms, it's important for me to think that this could be something more sinister, and to be aware of the possibility of GIST tumours, and to refer in for a diagnostic or more diagnostics if the pathway allows it to happen all in secondary care. That would be the best thing for primary care. But what would be the expectation from your end? How would the patient arrive at a specialist centre? Just so that we can help inform our patients of what might happen.
Well, I think from the entry point, it depends on whether the presentation is as an emergency or an elective diagnosis. That's probably the first thing. And the likelihood is, because of the nature of the symptoms, gastrointestinal tract, the majority of these patients are going to come through the surgeons or the gastroenterologist. So, for example, for me, the patient may have had an operation already in his local hospital if he presented with an emergency, such as a bowel obstruction,
yes.
because plainly you've got to get on with that. So that the local surgeons would have dealt with the acute situation and then refer up to someone like me and say, OK, well, look, please can you take the patient on, discuss at your meeting, and at that point primarily to decide whether additional treatments on top of the surgery are going to be valid or important for that particular patient. So that's really the emergency presentation. Okay. An elective presentation where, for example, you may send a patient of yours with perhaps a little bit of dyspepsia and anemia, let's say, to have an endoscopy at which the gastroenterologist carries out the endoscopy and he sees the very classical submucous tumour in the stomach, which I always think looks like a little sort of potato hanging off the wall of the stomach. And they say, oh, well, this is a stromal tumour, and then may send to the surgeon, but in an elective way. And then we would work that patient up from there. And the decision-making process might include perhaps not surgery. Maybe we would look at treatments other than surgery, or whether the surgery would be by an open operation if it's a very big tumour, or whether the surgery would be by more and more these days more likely to be by some form of keyhole surgery to minimise the impact.
So it's quite a complex, complicated MDT discussion. So where would you, Robin, and you, Charlotte, come in to this point in the patient's pathway? What patients do you offer ongoing treatment?
Well, we're often very interested in the radiology, so we'll look at the CT scan. Sometimes GIST can also be an incidental finding on a CT scan, and then we'll have an in-depth discussion with the surgeons about whether they should proceed primarily to surgery, or if it's a large tumour, sometimes we think about whether we can offer a treatment to possibly make surgery a little bit easier. We also, in our MDT, will discuss with our pathologists. So if it's after the fact and they've already had a biopsy or surgery, we can look at certain aspects of the pathology to try and predict what the behaviour of the GIST might be in the future.
You mentioned a treatment. What could you tell us a little bit about the treatment and what our patients might expect from it?
Well, the majority of GISTs are driven by a mutation in a gene called KIT. And there's a drug called imatinib, or Gleevec is the trade name, which is a very effective treatment for the management of GIST. It was first developed for patients with metastatic GIST, but more recently has also been brought forward into the treatment pathway and sometimes might be used preoperatively in patients with a large GIST, which needs to be decreased in size prior to surgery.
It's a small molecule, not chemotherapy. It's not an antibody, and it inhibits a protein called KIT, K-I-T, which is normally in this disease permanently switched on because of a mutation in the KIT gene. The benefit of giving patients preoperative imatinib is not only does it shrink the tumour and may then result in the patient not requiring a total gastrectomy, or in the case of a rectal GIST, an AP resection and permanent colostomy, but also at the time of surgery, the tumour is no longer metabolically active, it's quiescent, having responded to therapy, and there's much less risk of intra-abdominal dissemination at the time of surgery.
What's the prognosis, Robin, of patients with these type of tumours?
So, as Satvinder mentioned, the majority of patients can be cured with surgery alone, but there are patients with tumours that have high risk of recurrent disease, and those are the patients that we would select for post-operative treatment with imatinib.
And is that how is that given? Is that an infusion?
So that's a tablet medication.
A tablet.
That's
Okay.
taken every day.
Okay.
And for cancer treatment is relatively well tolerated, but inevitably does have some side effects. But in general, people tolerate it very well.
So what are the side effects that
So
we
it
should
can
be aware
include
of?
nausea, vomiting, fatigue, puffy eyes, some laboratory blood test abnormalities. But in general, as I say, very well tolerated drug.
And is your compliance good?
I suppose compliance can be a difficult thing to monitor and document, but in general, yes, I would say that compliance is good.
Some patient stories that we're going to hear at the end of this module talk about being able to work full-time whilst being on treatment. And is that more the norm with this type of tumour?
Yes, but most of our patients do manage to maintain a good quality of life and continue to work while on treatment.
That sounds very positive.
It is positive.
Would you recommend that we could offer in partnership or signpost our patients to? So we, Professor Ian Judson, who is also talking on this video, leads the medical advisory board at Just Support UK. He originally did the earliest trials with just tumours. Is this a go-to resource for our patients?
Yes, it's a fantastic resource for patients because the disease is rare. Very few people have actually heard of it, and it's great for patients to be able to talk to other people who have experience of the disease and
they can get in
more
touch with the charity and,
yes.
and have links. And also Macmillan and CR UK, I know, have got some pages specifically about just tumours for patients and GPs to look at, so that would also be very helpful.
It's interesting that you mentioned about compliance. I think one of the real advantages we have at specialist centres is we've got clinical nurse specialists, and these are nurse experts, and they really know about the management of side effects of these treatments, and they're always a very good point of contact for our patients and are available by phone, and I think that can be really helpful in signposting patients.
Agreed.
And the Just Support UK charity you mentioned also, as well as written information, they have patient forums, so patients are advising each other, and that's also, I think,
peer support is really valuable.
Helpful,
yes, especially for a tumour that's rare but can have some devastating consequences on your life. We're also, I was mindful that the patients that are on our story at the end of the video are quite young, and is that something that is because we know that cancer's on the increase because we have an ageing population, but is the incidence of patients diagnosed with GIST, has it stayed at sort of similar age group, or is that also rising in older people?
I think it's difficult to say. I think originally it looked like the incidence was increasing, but that's because just before we had specialist pathology, it was often wrongly classified as other types of tumours. And I think there's more awareness of GIST nowadays. I think we really see it affecting all age groups, and certainly in our clinics we see patients from 18 to 80 or 90 years of age. And I think it's important to emphasise that the treatment imatinib is generally tolerated well amongst all of those age groups.
You mentioned some side effects of imatinib. Could I just come back to you, Satvinder, and side effects of surgery? Anything, complications that we need to worry about?
Well, I mean, that depends on the specific type of surgery, whether it's going to be surgery to the stomach or the intestine. And I think the group, I think your point is well made, that in the younger patients, if you've carried out major gastrointestinal surgery, whether it's to the stomach or the intestine, but in particular to the foregut, to the stomach, then in a young patient you're going to have problems of the long-term nutritional problems of having either your stomach removed or part of your stomach removed, and that will relate to micronutrients, calcium, iron, bone quality. I mean, these are the things that I think about in my clinics with the younger patients, are those issues of how we're going to manage those patients as they get older and start to develop these problems of vitamin D deficiency, bone thinning, all these things, that they may wish to become pregnant and so on, and they've had major surgery, and all of that's got to be taken into account.
I think it's really important for GPs to have all of this communicated to them, and I think the vehicle that is now mandated as part of the updated cancer strategy with implementation of the recovery package and commissioning of end-of-treatment summaries, when they get to us and to the patients, I think GPs will feel a lot better informed, particularly pertinent to these rare tumours, where we've just not come across them. Many of us will not see a patient in our lifetime, although we diagnose cancer fairly more frequently in other tumour sites. I'm interested about the younger woman and the conception and contraception issues. Is it something that when they've moved on to needing, if they've needed to have imatinib, do you counsel them against getting pregnant, or is it something that's safe?
I think we have very little information regarding pregnancy and imatinib, and we usually advise
people. Trials on.
Yeah, precisely.
Yes, yeah.
So we'd usually advise people to
contraception.
And to maybe even if they are pregnant, to be off treatment. And
do you know if it affects fertility long term?
Again, we have very little data, very few data to guide us.
So patients can really be left with quite a lot of psychological issues at the end of this. So not only have they may be young and still trying to work and raise a family, they have issues as to worry whether the cancer is going to come back or not. And again, that is something that is really earmarked as a point of work for us as a cancer community to support our patients with the long-term effects of treatments. They might be cured, but at what cost was a Macmillan document that came out a few years ago. Patients locally to you, do they have open access to their CNS? Do they need to come back to their GP and be re-referred? How does your re-entry system work? I know that that's specific to the Marsden, but it might give my GP colleagues some way of sort of questioning what happens in their local pathways.
I think, as Charlotte mentioned, with the clinical nurse specialist, most of the patients would re-enter the system that way by contacting the
So
nurse.
they have that
They have
forever.
that.
What are the chances of it coming back?
We do have a way of trying to predict that, and when we're looking at what are the risks of a GIST after surgery, there's some criteria that have been laid out by two pathologists, and we're particularly interested in the size of the GIST, where it's come from in the gastrointestinal tract. As Satvinder said, it's most common in the stomach. If it arises in the small bowel, for instance, that's often a higher risk of coming back. Right. And also with the pathologist, they'll tell us what's the mitotic count. And that will give us an idea of what's the activity of the GIST.
Growing.
Some patients have very low risk GIST, and we know that they're very unlikely to come back. And those are the patients that we can safely discharge back into the community.
And without going into too much detail, very often very small GISTs are discovered coincidentally when somebody undergoes an operation for another type of cancer. And the incidence of those very small tumours may be as much as 30% from post-mortem studies. So there's a spectrum there.
How involved does the GP need to be when the patient is with you on treatment? Do we need to get involved in monitoring blood tests, liver function, renal function, which often happens as a special arrangement with, say, the rheumatology department in us. But do we need to worry about those levels or any other blood counts with our patients?
Most patients on imatinib, we'll do a blood test once every 3 months, and usually that can take place in the hospital. Sometimes we can see blood changes like neutropenia or liver function test changes. They're quite rare, but sometimes we will ask the GP to help us with that, particularly because patients are coming to specialist centres and often don't live that close to our centre. But we like to keep our GP sort of informed about what's happening and request that as needs be.
I agree that clear communication is always important.
It's really critical, and especially in where I'm coming from in Gloucestershire, with such a large geography with rural transport issues and things. So it is important that we work together as a system. Some people I know are have been recruited and consented to take part in the 100,000 Genomes project, and are people worried about a genetic implication? Are their children going to develop GIST tumours?
I think it's important that we can reassure the majority of our patients with GIST that it's not hereditary. There are some very rare syndromes associated with GIST and also neurofibromatosis, but that's something that we would consider looking at the patient's history.
And can you tell on a molecular level whether there is a prognostic indicator that is less favourable?
Well, as understanding of GIST has really increased, we can now look at molecular level and changes in the KIT gene and also the PDGFRA gene, which also can be affected. And looking at molecular changes there can help us to understand the behaviour of the GIST and also sensitivity to treatment.
I think that factors into a question you asked earlier on about specialist centres and the knowledge that we've gained about GIST over the last 20, 25 years has been a result of research, and it's very important that we carry on conducting clinical trials and laboratory research on these tumours. So again, emphasising the point regarding the value of specialist centres.
Value of specialist centres and clinical trials as well. Of course, we should be encouraging our patients to take part in trials. So what do you feel are the top 2 take-home messages?
Well, I think from diagnostics, it would be think GIST in a patient who has symptoms that are difficult to pin down, and you've been trying, think of a rare diagnosis.
Thank you.
And I think the second one is to advocate to your patient for referral to a specialist MDT for in-depth discussion.
So we, as GPs, we don't have direct access into a specialist MDT, but we should be aware that GIST tumours are so rare that actually every patient who is diagnosed with a GIST tumour should be offered to have had a discussion of their management at a specialist MDT.
Yes,
so we
correct.
could be on the alert to make sure that we receive that sort of paperwork, etc. That's great. Well, thank you all so much for your time this afternoon.
Thank you.
My name's Emma Tennant. I'm aged 48, and I was first diagnosed with GIST in January 2009, which was when I had emergency surgery, and they found an 11 centimetre tumour attached to the outside of my small bowel. I first knew something was wrong probably about a year before that. So I was tired and I was suffering from, I realised I was suffering from unexplained anaemia. I nearly fainted on the way home from work one day. And when I went and got a blood test, it was, my blood count was 7, where it should be 12 or 13. He didn't examine me. He didn't really ask me many questions. He just said, well, you're a woman, you're going to be 40 this year, it'll be down to your periods. But he just told me to take 600 milligrams of iron every day for the next 6 months and then come back and see him. I started to get really severe pain in my lower abdomen. By 4:30, 5 o'clock, my eldest daughter found me on the floor of the bathroom, doubled over in pain. By 7 o'clock, we had I was taking every painkiller I could find, and we'd called the emergency doctors. And I think by about 9 o'clock, we had an emergency doctor come to the house, and they admitted me to hospital. The next day, they got the CT scans over. They did an X-ray and an ultrasound. They told me there was something there, but they didn't know what it was, and that they would do emergency surgery. And that's when they opened me up and found this tumour, which a week later was confirmed as GIST. Generally, if you catch a GIST, if it's 5 centimetres or less, then the likelihood of it recurring is much less. So the fact that it had got to 11 centimetres by the time it was found meant that I was really high risk of it coming back. And again, that wasn't properly explained to me post-surgery by the surgeon that I had, probably because he wasn't a GIST specialist either. So the fact that when it came back again as well, that was another shock. So I now have cancer for the rest of my life, and my life is probably going to be shortened, and that may not have been the case. Post-surgery, I was told I was clear of cancer. They got rid of it with good margins, which is great. So I sort of just concentrated almost on, being cancer-free. I didn't really focus on GIST itself, what it had been, all the cancer, because by the time I knew I had cancer, it was gone, because, it was emergency surgery, and by the time I woke up and they said, oh, it was a tumour, it was out. So I sort of just concentrated on the fact that it was gone and trying to be healthy and, being grateful that I could live a normal life. On my final 3-monthly scan, I was told that it had metastasised and come back in a number of places in my abdomen. And at the same time, they told me they wanted to put me on Gleevec or imatinib, which is the first-line treatment for GIST, and that they would take my scans from 3-monthly to 6-monthly. I decided at that point to take things more into my own hands, started to really learn much more about GIST, got hold of GIST Support UK, found out much more about the condition and found support with them, and realised that I could actually ask for a second opinion. I continued with taking Gleevec for around 3.5 years. I also got, at that point, I got mutational analysis done on the tumour, so I could understand what mutation the GIST was, and mine was one of the rarer types, which meant that actually rather than the standard dose of Gleevec, I should probably be on double dose, so I was on double dose for about 3 years. At that point, everything was sort of being held stable. I didn't get much shrinkage. Some people have incredible results on Gleevec. Mine just sort of held the cancer stable. Long term, it's difficult to say really. It's just, keep taking the tablets and hope that it keeps managing the growth. If it stops managing the growth, then probably at this point in time, I'd be looking potentially at trials. I think for GPs, I'd just say, please take the time to consider other options. That just because somebody is a certain age, be that older, just often affects much older people than me, or 40 as I was. And a lot of the symptoms are quite generic. If somebody's saying that they're not feeling right, and that they say that they don't believe it's down to, I knew it wasn't down to my periods. I knew that was wrong. Please, check out more things, send them for a scan. A scan will very quickly tell you if there's something there or not. Known it was something I could fight for, or something that GP could have recommended for me, then that could have stopped my cancer coming back.
My name is Nick Pantis. I'm 46 years of age, and I was diagnosed just before my 40th birthday in April 2010. On this one particular occasion, which followed a number of runs where I started to feel more tired and laboured through running, and I couldn't understand why I was suddenly starting to get less fit. So on this one particular occasion, we'd run about 2 miles, and I literally couldn't go any further. It was like very, very bad indigestion. So following that event, I decided to go and see the doctor. The doctor gave me some tablets for indigestion, gave me a month on those, didn't do any good, was feeling worse and worse. Not dramatically worse, slightly worse. He then said, okay, let's investigate this further. So he sent me for a endoscopy, which they conducted, couldn't find anything. He still wasn't happy with me seemingly to be deteriorating slightly. First of all, ordered a stool sample, which indicated there was some blood in my stools. So he then sent me for a colonoscopy. And the most telling sign that there was something wrong was during the preparation for the colonoscopy, when the following morning, where if anything that comes out of you is going to be liquid following the prep for it. This is the morning of the colonoscopy. Mine was black liquid. So I went to the little hospital, just mentioned to the doctor that, is it normal for what's coming out of me to be black? He said, let's see. Did the colonoscopy and basically said, there's something inside you that's bleeding. We can't see anything up from the colon perspective, so we believe it's somewhere within the stomach. The following morning, I was given another endoscopy where they found a GIST, a gastrointestinal stromal tumour. It was sent off, the tumour was sent off for examination, and the most telling sign of it being a highly aggressive tumour was its mitotic count was in excess of 60. And for that reason, the decision was taken to put me on adjuvant imatinib for a period of a year initially, because the cancer drugs weren't only allowed it for a year. During that time, it was then extended to 3 years. So I was put on it for another 2 years. The 3 years ended in June 2014. So I came off imatinib and had the side effects, that some of the general side effects that you get with it. But when I came off it, I had a bit of a month to 6 weeks of feeling really poorly. And I was told that was sort of the effects of coming off the drug, quite a powerful drug for that period of time. That settled down. Now I have very, very small side effects, which may be just a lag from the drug, I don't know. But I get regular CT scans once every 6 months now, mainly because of the mitotic count and the fact that, the chances of it coming back are pretty high. And I was told that they would just keep an eye on me in the hope that it won't come back. But if it does, I'm in the right place to have it dealt with and treated. And touch wood, as of now, there's been no recurrence of of GIST. From my perspective, my doctor was excellent at not saying it's indigestion or you're anemic. Although they were on his radar, he suspected that there might be something else going on. And my advice to every GP would be, don't just assume it's one of the symptoms are just due to one of the common problems or common diagnoses.
Okay, so my name is Vicky Rockingham. I'm aged 44, and I was originally diagnosed with GIST in 2007 when I had an emergency operation. My youngest son, was born in March of 2006, and afterwards I started to become quite anemic, and I think I was slightly anemic before I'd given birth to him. I think it was just put down to the fact that I was a vegetarian and I just had a child, so I was put onto iron tablets, and they seemed to maintain my iron levels because I'd become very anemic before that. And then I continued to take these iron tablets, and then eventually every time I sort of tried to come off them, my iron levels would drop again. So I just remained on them through to the point that I became ill at the end of 2007. We were visiting some friends down in Dorset, and we'd gone out for the day, and I'd always sort of, sometimes in the afternoon after I'd eaten, I always had this sort of funny feeling, and I felt a bit sick, but didn't really think anything of it. And we were eating an evening meal, which was like a tomato pasta. So, and I was given a glass of red wine, and I just took a sip and was like, I really don't want this, which was a bit unusual for me. So, and then I started to feel really sick, and I thought I was coming down with a sickness bug. So I went to the toilet, and we were supposed to be leaving to go and see my family. And I thought, I just don't feel right. I'm going to see if I'm going to be sick, just sort of almost make myself sick. So I was sick, and there were like globules of dark red blood in there. So I went in an ambulance to Dorchester Hospital. They gave me an endoscopy where they put the camera down into your stomach, and they found a tumour within my stomach, and next to it was an ulcer that was bleeding. And they'd removed a tumour. They thought the margins were clear, but they weren't sure, so it would go off to the labs. And after they reckoned that after a couple of weeks I would know what it was, but they thought it was benign. And then about 6 weeks later, I was invited to my local hospital, Stepping Hill in Stockport, and they gave me the news that no, it was malignant, and that I would be referred to the Christie. And they had found some cancerous cells in the blood vessels, which indicated it might have spread. And they told me then it was a gastrointestinal stroma tumour. And so then I waited to be referred to the Christie. My first appointment at the Christie, they were lovely people, and they just explained to me that the labs where the tumour had gone to, they'd done a really good job. And so there was no real point in retesting it from their point of view. And they explained what a gastrointestinal stroma tumour was. I can't remember whether it was at that appointment or following ones that I then found out that I have wild-type GIST, which is the one that's a little bit less predictable in terms of they haven't yet found the mutation, and therefore the drugs that are available are slightly less effective. After that, obviously I had scans, and they couldn't find it anywhere else. So for 4 years, life just went on as normal, and I went for checkups. And I'd just gone down to 6 monthly checkups, and then they found in November 2011 shadows on my liver. So they started me on a drug called imatinib, but we always knew from the start that it wouldn't be effective because of my GIST being wild-type GIST. And then I was on that drug for about 6 months, but we realised after 3 months it probably wasn't going to work. It showed no signs of working. So then I went on to a drug called Tennant, and I was on that drug for nearly 3 years. The main problems that I struggled with were hand-foot syndrome, and my red blood cells dropping quite a lot. But I managed fairly well on that drug, and it seemed to be that it would hold things for 1 3-month period, and then after 6 months it would grow a little bit, and then the next scan it would be stable, and then the next one grow a bit. So about 2 years ago, so it must have been February 2015, they decided that it was becoming less effective, and at the same time we knew regorafenib, which is currently available on the Cancer Drug Fund, was going to potentially be taken off the Cancer Drug Fund. So they applied to have me put onto regorafenib, and I've been on that drug ever since. It seems, at first, it took me a while to get the right dosage because the full dosage I found intolerable. I was having really heavy nosebleeds, but I would get spasms all down my back and of my legs and my back at night. And I just after 4 days realised it wasn't going to work. So I dropped my dosage and then dropped it to half. But that was ineffective, so I'm back on 3/4 at the moment. And it seems to be a journey that both my consultant and I are going on, in that it's not been around that long, so we're learning at the same time how to manage the drug. And I had a couple of scans last Christmas which seemed to be showing that it might not be effective, but ever since then it has been effective, and it seems to be keeping things stable, which is good. Well, I have approximately, so this was about 2 years ago, 15 tumours now in my liver, and they're scattered throughout. I think they sometimes refer to it as peppering. So surgery is definitely not an option for me. The medical team at Christie had suggested silver bullets, which is known as SIRT, which is where they put little radioactive beads through your arteries into the tumours directly, and it's been very successful for secondaries from colon cancer and breast cancer. But unfortunately, NHS England wouldn't fund it because they said there's currently no evidence. And I think this is the problem for patients like myself with wild-type GIST in particular, and GIST. They're very rare cancers, so you sometimes need people to be brave in terms of funding treatments to get the evidence to see if it would work. But for now, I'm on regorafenib, and that's working. There will come a point in time where it will stop working, but nobody knows when that is. And so it's really about keeping myself as fit as possible. I still work full time. I would say the quality of my life is not always fantastic, but I just have to manage the side effects. And actually, if I think about it, being able to work full time, be a mum, be around for my children is the most important thing. And I'm managing to do that on this drug.